I can't hear you. You hear me now? All right, do all that again.
Yes. Finally. I was panicking going off and on.
I noticed. I thought something was wrong with your system or something. All right, so this is a dry powder inhaler, guys. This is a dry powder inhaler that you have to load, right? You load it with the discus. I'm sorry, the blister. The little peel that you put down in here is called a blister for the dry powder inhalers. This is one you have to load yourself. Put the top on, crack it a couple of times, and one fast breath in because it's a dry powder inhaler. Dry powder does not aerosolize, so you have to force it in. Okay, and make sure you rinse your mouth out. Okay, so this is one of the dry powder inhalers that you have to load. Okay, you have to load. This is what we call Spiriva. We use Spiriva with this one. And what I showed you when you couldn't hear me was the discus, the Advair, which is fluticasone and salmeterol. And how you do this one is you open it up, expose the mouthpiece, and then load it. Okay. It comes with about 100 doses, I think. I think there's 100 little doses. Every time you crack that or load it, it's going to pop one of the discus and it's ready to inhale. Put your mouth over it and one forced breath in, hold it a little bit and let it out. Okay. Rinse your mouth out. You tell your patient to rinse your mouth out after every dry powder inhaler. Okay. Because it's probably got some steroid in it. All right. This is another dry powder inhaler. What I said before that was we're going to do pre and post. You have to do pre-vitals and post-vitals when you do a breathing treatment. The pre and post-vitals include heart rate, respiratory rate, breath sounds, and saturation. We also would do the peak flow meter. Okay, I was showing you about a peak flow. This is a measure how much you can blow out in one forced quick volume, right? Called an FVC, forced vital capacity. So I'm going to take a deep breath in and one quick breath out into this, and it will shoot the meter up. Okay. Uh, this goes by your age and your height. There is a list, a chart. Whenever you buy one or open up one, it's going to have a list to say if you're a 30-year-old female, you should be able to blow this much. If you're a 20-year-old male, you should be able to blow this much. If they are 80 years old, of course, the volumes are going to go down. Okay. The older you are, the less you're supposed to be able to do. And the shorter you are, the less you'll be able to do. It goes by the height and the age. Okay. Because the height is how long the lungs are. Not if you're 4 feet tall and 700 pounds, you will have less volume than somebody who is 7 feet tall and 100 pounds. Okay. Because it's about length. Okay. The length of the lungs. So this is what's part of your pre and post vitals. If they have an obstructive disease, you expect these numbers to be low, right? Because you can't get the air out when it's an obstruction. Okay. I'll try to see if I can edit that first part, but if not, don't worry about it. You have to be watching me in silence for the first part. All right. Uh, so you do that pre and post when you do your breathing treatment. Okay. When they do albuterol treatment or anything like that, any sympathomimetic or adrenergic bronchodilator, I expect this to be better because it is a bronchodilator. And the more dilated my bronchioles are, the better flow I should be able to perform on here. Okay. All right. It's okay. Now, let's look at that MDI, meter dose inhalers. And like I said, I hope you guys are looking over those PowerPoints and all that stuff over the break because this is not to be played with. You only have one more after this. You only have one more section after this, and then and then we get ready for the final and oral and the final. All right. Metered dose inhaler, MDI. Metered dose inhaler is they have different types. This is one here, okay? That when every time you inhale it or squeeze it, it's going to give you a metered amount of medicine. Okay, either 200 unit grams per puff or 50 unit grams per puff, something like that, or micrograms per puff or whatever. This is how it comes out. Okay, so this one happens to be a placebo, of course, for teaching. But you'll notice how this one it tells you how much is supposed to be left. When it's full, it'll be down here to 150 doses, right? That's why inhalers are so expensive, because this is 150 doses of medicine in this one inhaler, okay? Like I said, when we're in the hospital and you give an albuterol treatment through a small volume nebulizer, right? It's about $200 per treatment, okay? And so this one here is 120. I'm sorry, 120 doses when you buy it, okay? Uh, so how this one works is you turns and cocks one time, and then you will push this button. I hope you can see it. See that? That amount was the metered dose. Okay, that was the medicine. You take that every 4 to 6 hours or whatever is prescribed. So for this one, I say you turn and cocks it and then push the button, and that's the medicine. Okay. So this was cool. This is just water. I think some kind of water inside of here. But this is this type. All right. MDI. Then you have the traditional MDI that most of us are used to seeing, which are these, right? Metered dose inhalers. You have your canister, right? This is what it looks like. This is the medicine. This one happens to be albuterol, right? Albuterol. This has 17 grams, okay, of albuterol per puff, 200 puffs in here, 200 metered dose inhalers, 200. Okay, that's a long time. You got a lot of it in here. Let's see what else is in here. What we can see. So you don't have to worry about none of the temperatures or nothing like that. This is the medicine, and this is the little holder that it goes into. Okay, this is the holder that it goes into. It fits down in here like that. Lock it in place. You would take the lid off of it and squeeze it. Now this is empty, so there's nothing coming out. But you would squeeze it one time, and it's gonna give you your amount. Okay, your metered dose amount. You just push it one time, it's going to give you your metered dose amount, whatever that may be. Okay, this is a metered dose inhaler. Now, when you think about metered dose inhalers, MDIs, we have to try to get that medicine, since it's not a constant stream like in a small volume nebulizer. It's just one puff, right? So you got to make sure you get that medicine all the way to the parenchyma. And the best way to breathe for medicine or MDI aerosol is slow, deep with an inspiratory hold, right? So when I'm doing an MDI, I have increased risk of deposition in my upper airway, because it's squeezed. It might be right up at the top of my mouth, right on my tongue, right in the back of my throat. I only got one, unless I just keep doing it, right? You don't want to overdo it, because these are concentrated doses, okay? And so when I do it, I have to make sure that I'm breathing correctly as I'm doing it, all right? So the best way to tell your patient to do it is to, when they put it in their mouth, they will start to inhale slowly and squirt in the middle of the inhale. Okay, you would pump it in the middle of the inhale. Don't shake it and squirt. Then you see people doing that all the time. That's incorrect. They're not getting the medicine good. What they need to be doing is like that. You start inhaling, because you're going to slow deep with an inspiratory hold. Well, in the middle of that slow and deep, as soon as you start inhaling, then you push it in. Okay, so it kind of fits into your stream and goes down into your parenchyma. But even with good technique, MDI still pose a risk of deposition in the upper airway. Okay, so in that reason, with an MDI, we usually use what? What do we use? What can we use in conjunction with the MDI to ensure better deposition? Spacer. The spacer. Spacer looks like this. And all you do is you stick the MDI inside. Okay, then you shake it up and you squeeze it. Now I can squeeze it first and then take a slow, deep inspiration because the aerosol gets trapped in here. All right, the aerosol chamber. Well, you squeeze it and your medicine gets trapped into here, and then I can take my time and slow, deep breath in, and it's gonna suck all of it in slowly into my breath, into my lungs. Okay, so this is a spacer. Okay, this is a spacer that we use with the MDIs. So what happens when I put that medicine in there? I don't know if you'll be able to see it well, but even if I had this one, see how it filled up with medicine? See how the medicine's still sitting in there? Because there's a valve in here that's not going to come out till I suck it out. All right? And so that medicine, see that? That's all your medicine still sitting there. It's in the chamber. And so now when I suck it in, it's going to slowly come into me, right? And that gives me a better chance for better deposition, all right? Penetration and deposition. That's why we use a spacer, especially with children, okay? Especially with children. And so with children, you might even have one like this. You see how it has a little place for the cushion. It kind of goes over the baby's nose and mouth, right? Or for a little bitty kid, and it's got instructions on there how you can put it over the baby's nose and mouth, right? And that way, because they're not gonna put this in their mouth, or it might be too big or whatever, so you can just put this over his nose and his mouth and squirt it, and then they just breathe. They'll breathe in, they'll breathe out like babies, but they're getting it. Okay, this is a spacer. They got different types, different sizes, different colors. They all the same. They are in use for the MDI. That's a spacer. MDI with a spacer. Okay, we recommend all people use a spacer. You have those in your department. You have just boxes of them. Okay, so you have a couple of those on your little cow. You have your little stuff that you have with you, and then when you have a new patient, Dr. Scott ordered a new albuterol MDI for Mr. Johnson. Well, you already got a little spacer on there. You go introduce it to him, teach him how to do it, and you administer it every many times you're supposed to do it a day. Okay. In the hospital, none of these medicines are self-administered. Even if Mr. Johnson been doing this this DPI for 20 years, he might have been on this before you was even born. But when he's in the hospital, he's under my care. Okay. And so this won't be in his room. I'll go get it out of his box or wherever it's located, right? And since there's medicine already in it, it won't be in his room. I'll take it to him, and then you can hand it to him. I got it, and do his little thing and rinse his mouth out and go on. But you have it. You keep up with it, and you have to chart it. All right. The only thing that stays in the room will be something like this that you have to load. They will have their own Spiriva one. Okay, it'll already be in that room, just empty. Right. You just go in that little drawer and get out this little Spiriva. You'll have the medicine though. You'll have the little blisters that are in like the little foil container, kind of like when you take a cold medicine, you have to pull the foil off of it and pop it out. You have that. You'll get that out the machine. You have to get his Spiriva out, scan it, and scan his wristband, right? Make sure it matches. And then you put the blister in there, crush it, and let them do it. Then after they're done, you'll leave this part. Of course, you'll open it, throw the remnants away, and leave this in his room, and you go on. And when you come back, it's already in his room, okay? But since this already has medicine in it, preloaded, you can't leave it in the patient's room. This is another discus. It's just a demonstration. They got different types of medicine. Advair is not the only one in the disc, okay? This also is a disc, but was a different medicine, okay? All right. Another dry powder inhaler. What is this one? Pulmicort. This is the Pulmicort one, okay? So I'll pass these around. Look at them. All right. So this is the Pulmicort, okay, which is a steroid, right? It's also a DPI that you have to take the top off of it, right? And it shows you. Pulmicort, and that is 90 mcgs, 90 micrograms, and it's a total of 60 doses in here. So every time you load it, you just turn it. You turn it. Hear that click? Every time you click it, it loads another blister. They're already in here, okay? And then there's a number here. See that little red place there? It's red because it's now empty. All right, it's red because it's now empty, but it will have a number on it letting you know you got 3 left, you got 10 left, 6 left, 5 left, so you know when you're running out. But this one's, man, this expired 2016, so this this is super old. But it still got medicine in. I can hear it, right? But this is the dry powder inhaler. This is the Pharmacology one. And you put the top back on it, seal it up, put it to the side. All right? That's a dry powder inhaler. Same thing. All right, let's look at the Ellipta. The Elliptia. This is another dry powder inhaler. Right? They could come in different shapes and sizes. Some of them are very, very expensive. Okay, but this is the Ellipta here. It's red because it's empty, been empty for years. But this is how you use this one. You will open up the top and expose the mouthpiece. Okay, when you open up the top, every time you open the Ellipta, it automatically loads it for you. So you don't have to do anything else. As soon as you open it, it's going to cycle a blister for you. One quick breath in and rinse your mouth out. Okay, this is the Ellipta. Okay, and this is another Ellipta. I'll pass the Ellipta around. There you go. All right, now speaking of the MDI, back to the MDI. What medicine is this, and what is it for? Tylate is what? Not chromium sodium, but nitrochromium sodium. What's the difference between Tylate and chromium sodium? Good. So the chromium sodium is Intol, right? And it is for asthma, prophylactic for asthma, right? But if they have asthma issues and inflammation problems, we can use Tylate, which is nitrochromium sodium, right? Nitrochromium sodium, which is Tylate, right? Which will not only treat prophylactically for the asthma, but also give them anti-inflammatory properties as well, okay? And this one also happens to be in a MDI. So you just squeeze it, okay? Let me see how long this one is. This one expired. This one expired, oh, okay, well, it expired in 2001. So it ain't too old. Expired in 2001, all right? It's kind of yellowish. This Tylate is a kind of yellowish medicine. You can see it up there. All right. And then finally, it's really all you have. Finally, of course, your small volume nebulizer. The small volume nebulizer. Here you go, man. Pass them around. I have to look at them. This is your small volume nebulizer. You got to make sure you're able to tell me every part of it. All right? And we also want to give everybody one. Give everybody one of these small volume nebulizers, so you can make sure you know how to all the parts of it. All right, this is the small volume nebulizer. Small volume nebulizer. Right here. All right, so it comes, of course, all broke down. Make sure you know the components of the small volume nebulizer. All right, so small volume nebulizer comes with a medicine cup, right? This is the medicine cup. And the medicine cup has inside of it a What is this little piece that goes inside the medicine cup? The baffle, right? You have to have the baffle or it's not going to nebulize, right? All right, so you have your medicines. Now, our small volume nebulizer medicines, our aerosol medicines, we use these right here. They look like this, okay? Look like little, they got different types, different sizes, different medicines, okay? So, but for instance, this one here is, what is this one right here? Tell me if you can tell, if you can see, you might not can. Well, this is levalbuterol. Levalbuterol, also known as Zopanex. What's the difference between this and albuterol? No. What's significant about levalbuterol? Only has beta 2. It only has beta 2, so you don't have to worry about the beta 1 heart effects, right? Because albuterol has some beta 1 in it, right? It has what, +1 beta 1 and +4 beta 2. Well, this one will be about +4 beta 2 and no beta 1, no alpha. That's why it's more expensive, okay? So we will use this one if somebody already has tachycardia. So that's why we do our pre and our post, right? Because if I go in a room and Mr. Johnson's heart rate is already 120, I don't want to give him straight albuterol, okay? I want to tell the doctor, hey, he's very tachycardic. Can we switch to Zopanex, right? And he or she will say, okay, that's fine. So we'll order Zopanex, and then we use this. So now we don't add to the tachycardia, okay? And so how you do it is you just take the vial, and you would tear off the top. So I'm going to use a normal saline. This is a normal saline. Anytime you see the pink ones in the hospital, these are normal saline, right? You use these for, sometimes you squirt them in somebody's nose and loosen up, the same saline stuff your kids use when their nose is stopped up. That's normal saline. We're going to learn about that today, though. We're going to learn about the percentage and all that because that's part of my mucolytics. So I'm going to use this so I don't waste these medicines. But you'll pop the top, tear off the top like that, and pour it into my medicine cup, okay? Put the top to my medicine cup on, and then I add this part, which is the T-piece, also known as the Briggs adapter. Stick that one on top. I have my reservoir tube, right? This is my reservoir tube and my mouthpiece, okay? And then, of course, I have my small bore tubing. One end goes here, and the other one goes to my nebulizer or my tank or my wall outlet, okay? Now, I don't have to use oxygen for a treatment. I can use air. If they don't need oxygen, then don't use oxygen, right? If they only there for breathing treatments, then, you give them a breathing treatment using the air. You don't have to give it through oxygen, okay? You only use the oxygen if they already own oxygen. You don't want to take them off oxygen and give them an air treatment, okay? So you just, that'd be your judgment. Now, so I would do this. This is my this is my small volume nebulizer, my SVN. SVN, okay? Small volume nebulizers have 20 cc's or less, right? Large volume nebulizers are over what? 250. I think it's 250. Okay, 200 or 250. All right. Another thing is, what if they don't have any lips, or what if their teeth are they have artificial teeth and they don't have them in. Sometimes they can't hold this well, or they don't have arms, right? What if your patient don't have arms? Then if that's the case, we can switch it to a mask. Okay, we can use a aerosol mask. Okay. If my patient is asleep or doesn't have the cognitive ability to hold this and take a treatment, or don't have arms or really hurt, ill, I can just take off the T-piece, right, and put on my aerosol mask. Okay, and now you have the same thing, except it's a mask and they don't have to hold it. All right, they don't have to hold it. So the small volume nebulizer can be used as a mask, or it can be used as a T-piece, right? Mouthpiece. Now, we encourage the use of the mouthpiece because that gives you better deposition and making them concentrate on how they're breathing and they're not talking and all of that. So it's better to use this one, but if they can't or they prefer the mask, give them the mask, okay? Either or is fine. All right. Now, you'll also learn that we can use these in conjunction with some things. Remember we talked about the Venturi mask and it has that little medicine port on the end? Well, I can simply put this part onto that medicine port. I put some tape on this end, and you'll have this Venturi mask on, and this is going through the medicine port. Not only the medicine, but it also protects the Venturi windows, right? The air entrainment windows. You know what you remember? Does everybody remember what I'm talking about? On the Venturi mask, okay? It's got that little protector so that the sheets don't cover it up and he get too much oxygen, right? Well, that little spot on the end has a piece for this. Stick this on there, put a little tape on this end, and I can run a breathing treatment without taking off the Venturi mask. So if you take this one off and put this one on, you don't have to do that. Just put that under there and run it to another line, and he's getting the breathing treatment as well, okay? All right. So those SVNs are yours to keep. Man, all right. Do what? Oh, yeah, I gave everybody a small volume nebulizer. All right, so these are, again, these are some of the medicines. I'll pass a couple of the medicines around so you can just look. I'm going to pass around. You have to look and see what it says. Let's see here. This one is ipratropium bromide. I'm going to pass around. Ipratropium bromide is known as Activant. Test tomorrow, so I hope you've been studying. This is chromium sodium. This one's chromium sodium. And I just passed a couple. I mean, they're all the same type of deal. But I want you to be able to see it. This is ipratropium bromide. This is albuterol. This is just a little teardrop. We call this one the teardrop. Albuterol. We usually use this one with ipratropium bromide. This is before they came together. Okay, this is before they made them already together in the duo nail. But this one's a teardrop for albuterol. And I pass out. Oh, and here's the duo nail. So you'll see what's on the back. Now, when you read this, I pass this around. You're gonna one end is gonna say what it is, duo nail. On the back is gonna tell you which medicines are in there. You can't really see it on the video, but they're on there. So I'm passing these out. Here you go, back. I'll pass out the duo nail, the chromium sodium, and the ipratropium bromide. All right. That's how your medicines will come. Of course, they will be in a full package. You have to open up the full package, and it will reveal one of these. Okay, they're not laying in the drawer like this. All right, this one here. This is my lidocaine. Lidocaine. We use lidocaine a lot before we do procedures. Before I do a bronchoscopy and put the tube down your trach and the camera, I will give a treatment of lidocaine to numb the airway. So then you don't feel me probing around in the lungs, right? So not only do we give lidocaine for numbing, tooth pain or before they cut you, they numb you under the skin. Before a chest tube, we use lidocaine. So we use lidocaine for a lot of different things, okay? We use lidocaine for a lot of different things. This is glass. This is a glass vial, and you have to just pop it, right? You just break the glass and then you suck it out and you do what you got to do, okay? But this is lidocaine, 4% lidocaine. We use this a lot in respiratory. All right, and that's that on that. And of course, today you're going to learn the ultimate mucomist, acetylcysteine. Acetylcysteine. This is mucomist. You want to learn what this is all about, how it works today. Okay? This is part of our mucolytics. So I got my acetylcysteine, my normal saline out. I don't have any other kind of mucolytic out today. All right. All right. 8:45. Take a break. Come back at 8:55. Take a 10-minute break. I'm gonna pause, and then we're gonna go into the mucolytic lecture, which should be about 20 minutes. I mean, it's just that's all you got left. Mucolytic lecture, and then we will break off into different mannequins, and make sure you understand, be able to show me the MDI, be able to show me the DPI, stuff like that for your lab. I'm gonna write the lab pages on the board so you can have all that together. We work on our pre and post stuff, and then we can get into a few sample test questions, stuff like that. I'm going to print them out because I don't think everybody has on the computer. So I'm going to print them out. Ones I don't have on the computer, I'll print out, and you can look at it that way. And we'll practice that. Recording. Right? Anticholinergics, only 2 medicines. Steroids is a couple, not too many on the steroids, but a few steroids. There's only a couple of the antibiotic, right? Tobramycin or gentamicin. So the ones that have the most are those specific sympathomimetic drugs, those adrenergic bronchodilators, which are your rescue medicines, right? The ones that work immediately. All right, so let's get into finish up that little part of the lecture of the mucolytics, and then we'll continue on. All right. So you note taking, know whatever you got out for the rest of this lecture. I went out of town. I wasn't able to do it online on the weekend, so I decided to knock it out today. Be even more fresh. Right at the end. All right.
What is the name?
Those MDIs, you're not gonna. Now, ain't gonna. Which one is 400 micrograms per pulse? I mean, you don't have to know that much on the MDI. You don't have to worry about this one. How many is in each unit spray? They're not gonna ask you nothing that deep. Okay. But my MCGs is micrograms per pulse. Micrograms. Yeah, micrograms. Yeah. But like you're gonna say, which one of those is 100 micrograms per pulse, right? The only one that you might see that has a difference is the Advair. Advair comes in 150, 250, or 250 and 50, right? Something like that. The fluticasone and the salmeterol, right? The fluticasone in this one's 150, right? Let me make sure I'm recording. Yeah. This one happens to be 100 to 50, so 100 of the fluticasone and 50 of the salmeterol, right? And I can't remember exactly the other one. I think the other one of them is 250 and then 250 and 50, something like that. Okay, but you won't have to know that albuterol because they're different. Okay, this albuterol here, this MDI here of albuterol is different than the one you may get, right? You might get a shorter one, right? It's still albuterol, but it's going to tell you on here how many unit grams per puff, right? So you won't have to, because all of them not going to be the same, right? The Ventolin, what are the two trade names for albuterol? Ventolin and Proventil. So you might get a Ventolin one that might have 80 milligrams per puff, and then the Proventil might be 100 per puff, right? So it just depends on the manufacturer on that, okay? But as far as the concentration of albuterol, you do know that, okay? You know the concentration, you know the receptor effects of albuterol, okay, period. No matter if it's big puff or a little puff, it's all the same on the receptor side, okay? Alpha, beta 1, beta 2. So make sure you know the generic name, the trade name, the concentration, the receptor effects, right? And if there's something special about the dosage as far as only do 1 cc or only do 3 cc's max, not to exceed, you know, stuff like that, that will be something extraordinary that you might want to make sure you remember that. But all of them might not come and tell you, you know, had to know you have to take this one 4 times a day and you can take this one 1 time a day, and there's not going to be that much detail on it, okay? But like I said, know as much as you can know on it, because you just never know how much you're going to need to know for a particular problem. So it's all laid out there for you. You've had ample time to study for this. Okay, you've got the days we've done it. You got the holiday break, you know, and tonight. So the weekend, you've had plenty of time, more time than usual, than they usually get. All right, so let's finish this up. I'm gonna share my screen. Share my screen. Pharmacology. Mm-hmm. Mm-mm. Mm-mm. They're not going to ask you the concentrations of medicines in the clinical. They're not going to ask. All they want you to know you know how to put it in that cup and give it to your patient. Know how to do the pre and post vitals. Right? That's all they're going to say. Okay, you're going to do these 3 patients, and I'll go over and do these 3 patients. Here go their medicines, right? And so you know you scan the medicine, scan the bag, tell them what you're giving them, give them the treatment, and then do your pre vitals, give them the treatment, do your post vitals, chart it, and move on to the next person. That's it. They're not going to ask you. You don't have to know that albuterol is a 0.5% solution and all those kind of things in clinicals. And that is the school part, right? Getting the clinical part is application. How do I use it? If the doctor wants me to do PEP, now I don't want to be in there. You don't want to be in there saying, okay, he said he wants to do CPT, and you pulling up a MDI or something, right? He said he want to do chest physiotherapy, and then you pick this up. So, oh, we're giving them, you know, that type of totally lost type of thing. Then you will be removed from the site. Okay, you know you can't be that far away. All right, but you got to know that CPT is the airway clearance devices, or my beating on the chest, or drainage, or whatever, however they want to do it, right? You got to know stuff like that, okay? It's not going to be that big of a deal. The main thing you're going to be learning how to do is when you get into the ventilators, knowing how to run those ventilators, knowing what the ABGs, getting the ABG, looking at the results and being able to fix those results with your ventilator, what the condition of the patient, is it deteriorating, is it getting better? Looking at the history, it's real medical work, okay? Sitting down at your computer, reading up on the patient, understanding some things, looking up some stuff on the journal websites if you're not sure, right? Conversing with your colleagues about different things to treat the patient, okay? This is just, like I told you, breathing treatments is a small slither of what you do, right? But you do have, it's a lot to learn, but once you learn it, it's a, you do it every day, it's routine. Giving a breathing treatment is the easiest part. The rest of the stuff is what takes the thinking, the disease process. How far are we? How do I go about treating this patient? Let me look at his ABG. What should be going on? Is he ventilating? Is he having a ventilation issue, or is he have an oxygenation issue? What am I going to change on my ventilator to fix it? What do I need to request or ask the nurse, could she or he give to fix this problem? Right? Some things I can do, some things I can't do. Okay? And so that's where the therapy comes in. Okay? The traits and understanding to keep the hygiene right and all those things is respiratory. Okay? Now, here goes the mucolytics. the last part of the lecture. Mucokinetics is to move mucus, right? To move mucus. We first can use dilutants like the normal saline or distilled water. Matter of fact, distilled water, right? Distilled water. When you do a large volume nebulizer or your Venturi setups, those aerosol face masks, aerosol T-piece, aerosol tray collar, those are your dilutants. You're just using distilled water. All of those bottles of water that we change out in those bags and stuff like that, that's just distilled water. Okay, that's where we start. All right, distilled water is used in humidifiers. The osmolarity is hypotonic. Okay, it will be absorbed into the interstitial space of the tissue and can cause edema if you got too much. And you have to watch out what patient you're dealing with. You don't want to give them too much water, right? Okay, so those are just your little dilutants. Mr. Johnson's cough is a little thick. You know, I give him a little bit of a aerosol face mask or something for a little while, let him wet it up a little bit. Or if he has a trach, put him on that too, because we have to keep it humidified, right? And so that just kind of helps move the mucus. Then we can go into something called isotonic saline. Isotonic saline, also known as normal saline. It has the same osmolarity of the lung. Osmolarity, you might as well say, is how salty is it, right? Is it because like your sweat has a salty taste? Well, normal saline is just like your sweat, right? It's like your sweat in a bottle. And what it is, we use the pink one. Anytime you have a pink vial, this is normal saline, also known as isotonic saline. Isotonic saline means same. Iso, same as the lung, right? It is a 0.9% saline. Now, that's not the concentration. Saline is coming either, normal saline is 0.9%, okay? 0.9% is normal saline, okay? Also known as isotonic saline. We use this for diluting drugs, or we can use it to squirt up in your nose because the boogers are a little thick. You can squirt these up in the nose and help run, or you can give them a breathing treatment with just normal saline to help kind of work it up a little bit, okay? All right. But mainly it's used to dilute medication. All right. So whenever I have something, a medication that's kind of strong, we can add some normal saline in it to dilute it down some. Okay. Normal saline, also known as isotonic saline. All right. The next one you have is hypotonic saline. Hello? Yeah, I'm checking on you. I'll call you back. Hypotonic saline. All right, that's going to be less than 9.9%, right? It's less than 0.9. It's hypo, so it's a little less salty than your lung or your body, right? A little less salty. It's actually 1/2 of the normal saline, which is half of 0.9 is 0.45. Okay, 0.45% saline. Hypotonic. So isotonic saline is normal saline, and hypotonic is less than. Okay, it's like 1/2 of the normal saline. Hypotonic is 0.45%. All right. It's used in the ultrasonic nebulizer sometimes due to the evaporation of water, and can increase airway resistance. You don't have to worry about that. Hypotonic. What you need to know about hypotonic saline is that it's half of normal saline, which is 0.45%. 0.45% saline. All right. Then we jump up. If that's not working, we can jump on up to hypertonic saline. Now, this is greater than 0.9%. It's about 5% saline. It is used to do what? Induce sputum. We use hypertonic saline to induce sputum. Right? What other thing did we say we use to induce sputum? What device? Ultrasonic nebulizer. Ultrasonic nebulizer can induce sputum. So sometimes we can use hypertonic saline in the ultrasonic, or sometimes we use a hypotonic because the ultrasonic nebulizer already is used for inducing sputum. You don't want to be too strong, right? It's really, so we might use just some hypotonic saline in the ultrasonic nebulizer and induce sputum. But if we want to use Without the ultrasonic nebulizer, like say you want to do it in this, the small volume nebulizer, if we squirt hypertonic saline in here to get you to cough up something, okay? If the doctor orders a sputum sample and they can't, I ain't got nothing, it's dry, I can't get it up, you give them some hypertonic saline and they'll cough you something up, all right? Huh? Yeah, you can just give it like this in the breathing treatment. Yeah, because you trying to get a sputum sample, so it's deep down in. They can't drink it or anything, or it can be too much to pour down the nose, so they'll need it in aerosol. All right. Osmolality is hypertonic, so it's way saltier than the lungs. Way saltier. So if you were to taste it, it would be super salty. Okay, hypertonic saline. About 5%. It's about 5%. Now, it's so strong or so salty, it can cause a bronchospasm. So you have to be careful, especially in those people who have hyperreactive airways. The hypertonic saline can cause the bronchospasm. You're like, ooh, they breathing that salty. Can cause, bronchospasm. So you have to be careful. Sometimes we may give it with a adrenergic bronchodilator, right? So that don't happen. Okay? So that doesn't happen. All right, now, that's the lightweight stuff. Now we get into the actual prescription stuff. Mucolytics. Mucolytics. These are medicines that are designed specifically to break down or combat mucus in their own way. Okay? The first one is called acetylcysteine, which is the generic name for Mucomyst. Here it is right here. This is acetylcysteine, known as Mucomyst. Okay? It has a rotten egg smell. If you ever use Mucomyst and you smell it, you'll know it's Mucomyst. Okay? Reason because it's got sulfur in it. All right? Mucomyst works by breaking down the disulfide bonds of mucus. How does Mucomyst work? That's his claim to fame, right? That's his pharmacodynamic, right? Pharmacodynamics of Mucomyst is breaking down the disulfide bonds. So you have to know that term, pharmacodynamic. How does it work? How does a medicine do what it do, right? And so if you get a question, say, what are the pharmacodynamic of Mucomyst? You got to know it will work by breaking down the disulfide bonds of mucus. Mucus is bonded together with two sulfides. And the Mucomyst will go in and break those bonds down and make the mucus become less viscosity and helps you expel it, okay? Like melts it down almost, all right? Mucomyst comes in either a 10% or a 20% solution. This one here happens to be a 20% solution. This is acetylcysteine, 20%, okay? You use this one for the thick or mucoid secretions. If somebody just need to cough up a little something, you don't have to break out the Mucomyst, all right? But if they have a lot of thick, tenacious, bubblegum-like secretions, you need to break out the Mucomyst, okay? Break out the Mucomyst. But now it can cause a bronchospasm, so it must be used with the what? Bronchodilator. Mucomyst must be used with the bronchodilator. So, for instance, the doctor orders 2 mLs of 20% Mucomyst to the patient. Do you give that order as ordered or not? No, you need to tell the doctor we need what? A bronchodilator with it. Okay, it has to be given with the bronchodilator because it could cause bronchospasm. Okay, all right, and of course you discard it 96 hours after opening it. Okay, that's not going to be on the test. Acetylcysteine, the pharmacodynamic of acetylcysteine is breaking down the disulfide bonds. It comes in a 10 or 20% solution, and it must be used with a bronchodilator. The trade name for acetylcysteine is Mucomyst. Okay, that's how you would do that card. It's the only one, okay, for acetylcysteine. Now, the next mucolytic, sodium bicarb. Sodium bicarb. Now, off the top, you already know what is the pharmacodynamic of sodium bicarb. what's it gonna do? Raise the pH of the sputum. That's how it does what it do. When I say do what it do, like they say, that's what makes it do what it do. That's its pharmacodynamic. It raises the pH, and when you raise the pH of the sputum, it breaks the viscosity down. Okay? It makes it thinner. All right. The higher the pH or the more alkaline the mucus is, the thinner it is. Okay. That's why they encourage alkaline water and stuff like that to drink that. You've heard people saying, "I'm gonna get me some alkaline water." They'll sell some alkaline waters in the store because that helps keep your mucus and stuff in your body down. Mucus is all over your body. And a lot of people believe if you can beat the mucus issue, you can beat any disease. Because every disease does something to your mucus in your body. Okay? AIDS, everything. All right? And so having an alkaline system or drinking alkaline water and stuff like that can help keep that mucus thin and it at bay. All right? Doesn't get thick on you and get trapped in different areas, become purulent in other areas of the body. Okay? So that's what it does. Sodium bicarb raises the pH of the sputum. All right. That pH elevation will break the viscosity of the sputum down. Right. You give sodium bicarb 2 to 5 mLs of a 2% solution 3 or 4 times a day. Okay. Now these mucolytics, the test questions or what you need to know for these mucolytics for this test will be mainly how they do what they do. What they are, their names, and how they do what they do. Sodium bicarb does not have a trade name. It's just straight up sodium bicarb. Okay. Number 3, the third mucolytic is deoxyribonuclease. That sounds just like what? DNA. So of course it must do something to the DNA, right? Deoxyribonuclease mucolytic is the generic name for Dornavac. Dornavac. Dornavac is deoxyribonuclease. How does it work? It has a proteolytic enzyme that breaks down the DNA bonds of the sputum. Remember we talked about the contents of sputum? It says got 90% water and got debris and DNA. If somebody hawk up a Luke and spit it on the curb, that's DNA. If you're trying to get somebody's DNA, you can get it from that. Right? There's mucus has DNA. All right. So mucus, what we do if we want to do it this way, we can give them this medicine. The Dornavac will break the DNA bonds down, and that'll make it thinner. So there's a lot of different ways to make mucus thinner, right? And everybody's kind of capitalizing. We talked about alchemy and medicines in the discussion. One company want to go about it this way, another company might go about it this way, right? And it's trying to sell you a different product. Well, deoxyribonuclease, aka Dornavac, breaks down the DNA bonds of the sputum. Okay. And last mucolytic is Dornase alpha. Dornase alpha is the generic name for Pulmozyme. Pulmozyme. Now, how does it work? What is the pharmacodynamic of Pulmozyme? It genetically engineered peptide proteolytic enzyme, right? It breaks down the extracellular DNA in the purulent secretions. So it's close to Dornavac. Don't get caught or don't confuse deoxyribonuclease with Dornase alpha. Okay, deoxyribonuclease, which is Dornavac, just simply breaks down the DNA bonds of the sputum. But if I have sputum that seems to be purulent in nature, right? In my cystic fibrosis patients, they have a lot of purulent secretions. What's purulent mean? It's pus. Purulent is pus. Okay? Pus comes from dead white blood cells, right? When white blood cells go to an area to fight, when they get killed and they die, they turn into pus. That's what pus is, dead white blood cells. And so cystic fibrosis patients have a lot of infections, constantly infected. Their lungs constantly got some type of infection. Very, very sick. And so their mucus is not only thick, but it's pus. It's thick and it's laden with pus. That's called purulent secretions. So Dornavac not going to work for this person, right? I'd rather use Dornase alpha for him because if it's a cystic fibrosis patient, then I know I'm going to have some pus to deal with in the sputum. So not only does it break the DNA bonds, but it breaks the DNA, breaks down the DNA in the purulent secretions, okay? It's used to manage purulent mucoid secretions in patients with cystic fibrosis. So the main thing is Dornase alpha is the generic name for Pulmozyme. It is used in my cystic fibrosis patients. Whenever you see Dornase alpha, or they ask you what medicine this patient came in, was 14 years old with cystic fibrosis, you already know I'm going to give them some Dornase alpha. I already know that's one of the treatments that's going to be given, okay? You got to be able to link these medicines with these conditions, right? Cystic fibrosis will be your Dornase alpha or your Pulmozyme, right? Somebody who has asthma with inflammation, you're going to give them neochromium sodium, right? That's for prophylactic treatment of asthma and inflammation. You know what I'm saying? That's how you have to be able to link these conditions with some of these drugs, okay? That's all of the mucolytics, guys. That's the only mucolytics you have. You have acetylcysteine, which is mucomyst, works by breaking down the disulfide bonds. Sodium bicarb raises the pH of the sputum. Deoxyribonuclease, also known as Dornavac, breaks down the DNA bonds of the sputum. And Dornase alpha breaks down the DNA bonds of purulent secretions, right? In our cystic fibrosis patients. You're going to learn all about these different diseases on Wednesday. We get into hyperinflation and restrictive and obstructive diseases. Last unit. The last unit will start on Tuesday. Yeah, after the test. All right. Last type of drug that we have in last drug in pharmacology. Surface active drugs, and it's only one. The surface active drug we use is ethanol, aka vodka. Okay? Ethanol is the generic name for vodka. Okay? Ethyl alcohol, that's what you drink. That's the alcohol that's not the iso, how you call the other one? Isopropyl alcohol. Isopropyl alcohol. You don't drink that, right? That's the one you put on your cuts. Ethyl alcohol is the one you drink. Everclear, vodka. Yeah, vodka. Put that in there. Yep. Vodka is used as a surface active agent. What it does is reduces the surface tension of the bubbles. Now, we use ethyl alcohol for pulmonary edema. All right? It's used to treat pulmonary edema. Ethyl alcohol, aka vodka, is inhaled to treat pulmonary edema. Pulmonary edema is fluid in the lungs, but the fluid in the lungs from pulmonary edema, guys, is frothy. Okay? It's frothy. Hold on 1 second. Okay, I'm connected. Good. Okay. All right. And so when we have pulmonary edema, it's usually pink and frothy. So if you're looking at a patient, everybody look up here, and the patient has a trach or whatever, and their trach is oozing pink, frothy secretions like bubbles, that's pulmonary edema. All right. If you drink a beer or ever seen a beer, the fuzz that's on top of a beer, that's what's in your lungs. So it's the reason why we have to do something about that is because if I try to suction that, I'm not going to do nothing but get air. You can't, if you put a straw on the suds, you're not really going to get anything, right? But air, okay? And so I can't suction you out. I can't clear the lungs unless I turn those bubbles into liquid. And how I turn the bubbles into liquid is to decrease the surface tension, right? And I do that with alcohol. So if I know a patient has pulmonary edema, then the doctor may prescribe alcohol, right? Vodka. In a little vial. It goes in a small volume nebulizer, right? and they breathe it in, and it breaks those bubbles, it pops those bubbles. So then when they become more liquefied, then I can suction them out, or I can turn them and they can cough it up. Okay, that is used for pulmonary edema. That is ethanol, which is ethyl alcohol, aka vodka, and the dosage is 5 to 15 mLs of 30%, 50%, every 30 minutes for 2 to 4 treatments. Now, you have to be very careful because, like I said, when I was in school, we tried this. Of course, when they gave us a small volume nebulizer, went home and put a little vodka in there, and you will feel it. Okay, uh, you will feel it, and it bypasses the systemic effects. You don't have a stomach ache, a hangover, none of that, right? Because you're inhaling, it's going right into the bloodstream immediately, bypasses the stomach. And but the problem is, it not for one thing, it can cause a bronchospasm. If you ain't careful, you're at home trying and you close up on you, then you panic. Okay. The other thing is it bypasses the liver, and the liver is what filtrates alcohol, right? And so now you're not going through the liver, you're just getting pure alcohol into the bloodstream. That's why it just takes a couple of breaths and you got a buzz. Okay, just a couple of breaths. But it can also kill you and go into alcohol poisoning faster because the liver is not filtering it out. That's why people who drink all the time have cirrhosis of the liver, right? Because alcohol is constantly going through the liver and it's filtering and filtering, and you're tearing it up. It's scarring it up. Alcohol will scar the liver up so bad that you need another one, right? You die from liver failure. Cirrhosis of the liver. Most
I've seen patients with jaundice,
uh-huh.
and like again, there's like two lights above the bed, but there's a giant spotlight above the bed, and it looks like the patient's below it.
Mm-hmm.
It's crazy.
Yep, jaundice comes from having liver issues. Mm. Yeah, it's not, yeah, it's not pretty because you only got one liver, right? You're not like you have two kidneys. You have to get a liver transplant. And so what happens when your liver is messed up, you start having jaundice issues. The whites of your eyes get yellowish. The palms of your hands can get yellowish, your mouth and stuff. I've seen people that look like orange walking around Methodist because it's a transplant center. They're about to get a liver transplant. And before that, they fully jaundiced. It looked like Donald Trump's hair, right? I'm serious. I looked at one man, I was like, he is, I mean, actually orange like this almost. I thought it was a joke, but I realized I was in the, when I was a student then, but I realized I was in the transplant unit, right? And that's, they were, he's walking around, but he was coming in and out. He was getting set up to get his liver transplant, right? But once the jaundice is so bad, it discolors you, right? So that's why I don't recommend recreational inhalation alcohol, okay? But I do recommend it for your COVID patients that I'm trying to get that to be used for COVID treatments because we already use it, right? And we know that COVID responds well to alcohol. Alcohol can kill it in like a minute as soon as it gets on it. But and since COVID is a lung disease, if we can get early on when a person first is diagnosed with it, if we can get alcohol treatments in them every now and then, maybe once or twice a day or something like that, to help kill the virus that's in the lungs and maybe shorten the time and the veracity of the disease, right? So I'm working on a journal right now to try to see if we can start that, okay, in this treatment of COVID. But believe me, when I come home from the hospital, if I've been exposed or I'm around a patient with it, I do this at home myself. I don't take the chances, okay? But I can't tell you to do that. But how it does, it works by altering the surface tension, thus popping those bubbles. So all those little frothy bubbles just pop, 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 and they turn into a liquid so you can suck them out. So pulmonary edema is used, it's treated with ethanol alcohol breathing treatment. Okay? That completes the pharmacology lecture. That's the only thing we had left was mucolytics. Now, I'm going to put a little mucomist in a treatment so that you can smell it, because it is you don't have to breathe it in, but I'm just letting you smell it so you can see that it is unique, right? It's unique, and if you smell it, you'll know that's what it is. It works by breaking down the disulfide bonds, right? So it has a sulfur agent in it. All right, it has a sulfur type agent in it. And I don't have a needle, so I can't aspirate like I want. So I'll just do that. That's enough to. Oh yeah, that's enough for you to smell it. You see me smiling under my mask.
Yeah, I don't even like it.
All right. It goes away quick, and it doesn't taste nice. I did one time. It doesn't really taste nice. Oh, you gonna smell it anyway.
Trust me.
All right, so this is the Mucolytics.
I think that's good.
And you just come up and place it,
You laughing on the inside, eh? No.
like real good.
Pretty intense part.
Once I stop it, it's gonna go away. But that's good to know. You know what medicine you're taking is on. It's good for you to know. But if you give me, if somebody tell you that that's Mucolytics, you don't smell it, that ain't no Mucolytics. I know what Mucolytics when I smell it. Just like you want to know Pseudomonas, the disease or a gram-negative disease of the sputum. You're going to know that when you leave the door. If that patient has a trait and has Pseudomonas, you can smell it at the door. It's extremely funky. Okay, nasty. It's like, ugh. You do that, if you're not used to it. But then you got to be right there with it, suctioning in and out and stuff like that, right? You got to be used to it. All right. So those that are online, which I think let me see who all on here. Miss Cummins, you still here?
Yes.
I'm gonna put up a couple of practice questions that you can look at while the students in here will be actually doing on paper. But after that, I go over a few of those, just some sample questions to look for sample test questions. Okay, how it looks. We'll do that, and after that, we're gonna do the lab, and we're done. Okay. But so when I get done with those, I'm gonna put up a few test questions on here for you, Ms. Cummins. But after that, I'm gonna stop the whole lesson. I'm gonna stop the whole recording and go into the lab because today's lab day. Okay, so you're gonna have to make up your lab when you come back. All right, so let me pull this up. Yeah, Ms. Cummins, you can do a couple at a time because, like I said, I won't be able to show you the whole thing at one time. Can you see? Can y'all see my screen? It says, huh?
You're not showing any questions.
Oh, okay. But for those of y'all are here, you're gonna have it on a piece of paper. All right.
Yeah, it says open in Safari, but it won't let me actually log in.
All right, here we go. Y'all have y'all on paper anyway. Do the first pages. 8.
Is there a meeting ID that we need to join the daily Zoom thing?
And you better just put my link in the thing.
It never lets me do it.
But I can know what I do have a meeting ID. He does have a meeting ID.
That might be the way I have to do it. I don't know why. I have both of mine.
You took over here and try to plan on this. Believe me, you're gonna do that. Well, at least the guys will. You'll poop in patient's room. I said, guys, you're going to poop in a patient's room. You're gonna poop, especially if it's already stinky in there. You're gonna let it go. You're gonna let it go. Y'all might not, but we will. Y'all might not. I did that one time when I was a little younger in the game, and it was these rooms with these curtains in the ER, and I went into one and I had to go. I mean, I had to poop. And I pooped, but I didn't know it was another patient on the other side. And after I did, I was like, ooh, and he just started laughing. He wasn't even like, oh man, what? He was laughing, and it scared me because he started laughing out of nowhere. I didn't know he was there. I was embarrassed. I just walk on out of there. Walk on out of there. They used to it. Nurses used to it. So work on those front and back 1 through 8. I'm going to pause the recording, Mr. Cummings, and you can. Yeah, I'm not going to be recording these questions like that because some of these questions. All right, we're going over a couple of these questions that we gave out. Number 1, which of the following or which group of drugs would inhibit phosphodiesterase, thus thereby increasing levels of cyclic 3,5-AMP? Mr. Simmons, just say the word. Acetylcysteine. Now, acetylcysteine is Mucolytics. All right, which one blocks phosphodiesterase, Ms. Thomas? Oh, anybody? C. Xanthines. Remember, we said xanthines block phosphodiesterase. So once we get bronchodilation, once the sympathomimetic drug bronchodilator gives us bronchodilation, then phosphodiesterase comes on the scene and tries to take us back to normal tone, right? But if we want to block phosphodiesterase, we have to use an xanthine, okay? Somebody give me one of the xanthines. Who? Nicotine. No. There's 2 xanthines that we give. Those are anticholinergics. 2 xanthines that block phosphodiesterase. Theophylline and aminophylline. Theophylline, so if y'all studying those cards and making those cards, there's only 2 xanthines, theophylline and aminophylline, right? Remember we talked about how you have to do a loading dose of those. You give a loading dose and you check the serum levels to make sure that the theophylline or the aminophylline is still in the system. All right, so those are the 2 xanthines. Number 2, a patient is having an acute asthma attack. Vital signs are pulse 125, respiratory rate is 25 and labored. Blood pressure is 145/84. The lips show cyanosis. We should administer which one of these drugs? Patient having acute asthma, right now, they're having asthma. What do you give? A, adrenergic bronchodilator. Rescue drug. We're going to open them up right now. I don't want to give a long-acting bronchodilator, right? That's the one that take too long to kick in. Patient is having an asthma attack right now. Lips turning blue. Heart rate is high, right? Now, with that heart rate, which one of the adrenergic bronchodilators do you recommend? With that heart rate being what it is. Huh? No, I don't want to make it no higher. No, it's already high. Now I said, which one of the adrenergic bronchodilators do I want to give? Not bronchosol. Yeah, levoalbuterol, Xopenex, because Xopenex does not have beta 1. Beta 1 gives you increased heart rate and strength of contractility. So somebody's heart rate already 125. I know he needs a bronchodilator, but I don't want to give him albuterol or bronchosol. I want to give him one that doesn't have beta 1 effects, because beta 1 gonna make his heart rate go even higher. Even higher. All right. Number 3. Hypertonic saline is indicated for what, Joshua? Sputum induction. Number 4. Ribavirin is given in a spag for the treatment of what, Kayla? RSV. Number 5. Sympathetic stimulation of the alpha and beta 2 will give me what? So alpha and beta 2, if they get stimulated, Ms. Scott, what's going to happen? 5 is B. 5 is B, which is 1, 2, 3, and 4. You're going to have vasoconstriction because of the alpha. You're going to have a decrease in cyclic, no. Well, 1, 3, and 4. B, I'm sorry. Yeah. B, you said B, right? Yeah, 1, 3, and 4. I'm about to say, wait a minute now. 3 is bronchodilation, right? Because of the adrenergic bronchodilator. You're going to, beta 2 is going to give me bronchodilation. And then 4 is increase in cyclic 3,5 AMP. Great. That's cyclic 3,5 AMP. Don't forget, that's your friend. That's bronchodilation. That gives us bronchodilation. All right. Number 6, adrenergic stimulation of beta 1 results in what? Mr. Simmons. B. Yeah, 1 and 3. Increase in strength of cardiac contraction and increase heart rate. So you got to look at your stuff. You got to look at your pre and your post. That's why you do a pre and post. Patient's heart rate is already 125, and that last problem, he's having an asthma attack. We got to give him an adrenergic bronchodilator to open him up, because his sats are dropping, his lips turning blue, right? But when I got a choice, then I'm gonna think about a Zopanex, right? Because his heart rate is already high. Okay, so when you have a patient whose heart rate is already tachycardic, you know that the adrenergic bronchodilators will hit on beta 1, beta 2, and alpha, right? So you got to pick which one is best for that patient. Whichever one has the least beta 1 is one you want to choose when somebody has a high heart rate, right? Or blood pressure super high, right? That's what you have to watch out for. Okay, that's kind of decisions you'll be making. All right. Number 7, which of the following is a strong contraindication for the use of mucomist when not in a combination with a bronchodilator? So which one of these issues would be a contraindication, a strong contraindication, if I'm going to use mucomist without a bronchodilator? Kayla. Huh? A, no. Think about mucomist. Mucomist can cause what? Bronchospasm. So which one of these conditions would I really not want to give this treatment to without a bronchodilator? C, asthma patient. Asthma. All right, number 8. Some of the side effects of adrenergic bronchodilators include what? What are some of the side effects on 8, Ms. Thomas? 8 is A. Good. 1, 3, and 4. Palpitations, dizziness, and tachycardia. We haven't read anywhere where it makes you sleepy. If anything, it's going to keep you from sleeping because you're going to be anxious and nervous, right? Remember, albuterol can make you jittery. Nervous can make your heart rate go up, palpitations, right? And tachycardia. Good job. Number 9, the trade name for isoetherine. The trade name for isoetherine, Ms. Rose. Number 9, tell me the word. Number 9 is B, bronchosol. Bronchosol, aka isoetherine. Isoetherine is bronchosol. Number 10, for a prescription to be valid, it must contain what, Joshua?
I put 1, 3, and 4.
It should be patient name, duration of the treatment, and dosage. 1, 2, and 3.
See, it's confusing because for prescription, I mean, at home, my prescriptions have a pharmacist signature on it.
Yeah, but no, it has a physician signature. For a prescription to be valid,
Yeah,
it has to have a physician. The pharmacist doesn't have to sign it. Now, if they got a controlled medication, he might put his initials to make sure its count is right, right? If it's an opiate or something. But as far as the prescription paper itself, his name's nowhere on it.
So it's 1, 2, 3.
1, 2, and 3.
Yeah.
Number 11, the greatest beta-1 side effects are found where? So which one of these drugs has the greatest beta-1, Ms. Scott? Not racemic epinephrine. The greatest beta-1. Which one? C. Isoproterenol. Isoproterenol, also known as what? Isoprel. Isoproterenol. See, that's the kind of questions you may see. This drug has the greatest beta-1 receptor site, right? It's also known as isoprel. And then the choices may be all generics. You got to know that isoprel is isoproterenol, right? You got to know that's what they're talking about, right? They might not give you the trade name, and they may throw that trade name in the question and ask you for the generic. Right? That's why you got to know these drugs. Number 12, the breakdown of 3,5-AMP ends what, Kayla? Tell me the word. Huh? Bronchospasm? No. Bronchodilation. The breakdown of 3,5. Now, the production of 3,5 gives us bronchodilation, but the breakdown of it ends bronchodilation, right? And who breaks it down? Who comes in and breaks down 3,5-AMP? Phosphodiesterase. So if I don't want phosphodiesterase to do what he's doing, I give her what type of drug? If I don't want phosphodiesterase to break down my 3,5-AMP, I get something. I want to get a drug that blocks phosphodiesterase. Which kind of drug is that? Xanthine. And the two xanthines are aminoalphalin and theophylline. Okay. All right. Number 13. Which of the following drugs is used prophylactically in the treatment of asthma? Mr. Simmons. C? No. A, chromium sodium. Chromium sodium is used for prophylactic treatment of asthma. Prophylactic treatment of asthma. 14. Bronchosol has the greatest effects on what? Ms. Thomas? No, it's not B. Number 14. Bronchosol has the greatest effects on what? D. Are they equal? Does bronchosol equal? Is beta-1 and beta-2 equal in bronchosol? It's C. C, beta-2. Matter of fact, I think in my mind, I think it is beta-2. Beta-1 is 1 and beta-2 is 3. Right? That's why it's not as good as albuterol. Albuterol is 1 and 4. Right? But the bronchosol has its greatest effect on which one of the receptor sites, and it should be beta-2. 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 All right. Number 15. Number 15. As a respiratory care practitioner, the primary route of administration for our medication, Ms. Scott, is yes, aerosol. Aerosol. Number 16. If you receive an order for metaproterenol 6 puffs QID, what should you do? On number, I'm sorry. I don't know what I'm thinking about. Q12, you're right. 16. If you receive an order for metapaterenol, 6 puffs, Q12, what should you do? 16. Somebody tell me. Phone the physician for clarification because the order is inappropriate. Order is inappropriate. So how should metapaterenol be given? Huh? How should metapaterenol be given?
Yeah, maximum dose is 3 cc.
3 cc, but how is it given?
Oh,
Yes, inhale. But how should it be given? Metapaterenol. Let me go to the notes and let me find it. So at the beginning.
Like MDI?
Yeah, I'm saying how should it be given? How should metapaterenol be given? I'm going to it now. All right, metapaterenol.
It doesn't give us that
So metapaterenol says dosages 0.2 to 0.3 mLs, TID or QID. Maximum dose is 3 mLs. So is it given MDI at all? No.
That'd be an IV, right?
Huh?
It'd be an IV at that point, right?
No. What I'm saying is it's aerosolized. It's given in the breathing tube. It's not given as an MDI. Metapaterenol is not offered in a MDI. They told you to give 6 puffs. Like 6 puffs. Metapaterenol is not even given as an MDI. It's given only as a aerosol. It's given 0.2 to 0.3 mLs, TID or QID. Maximum dose is 0.3 mLs. So that's when you ask me, do I got to know the MCGs and all that? You got to know if it's an MDI or can it be given a MDI or not, right? Metapaterenol is not a drug that's given MDI. That's why you have to, like I say, you've had a lot of time to study these. These are the basic meds. These are the first meds in the first lectures. Okay? These are the ones I said, these specifics, you got to know them like the back of your hand. All right. Number 17, the maximum dose for isoethylene. Maximum dose for isoethylene, Kayla, is what? Not sure. Okay. Isoethylene. What drug is isoethylene? Bronchosol. Okay. So what's the maximum dose, Miss Cummins, of bronchosol? Huh? Oh, okay. Just tell me the number. 0.5? No. What'd you say? 1 cc. 1 cc. If I look at it, isoethylene, right here in my notes. Isoethylene is a 1 to 100 ratio or 1% solution. Alpha 0, beta 1, 1, beta 2, 3. The dosage is 0.25 to 0.5 mLs. Maximum dose 1 cc. Yep. All righty. Number 18. Ms. Scott, the generic name for mucomyst is what? Acetylcysteine. Good. Acetylcysteine. Acetylcysteine. All right, so now you see how you would have done if you were taking it today. Like I said, you have to make those note cards for those medicines. You have to do that. You cannot not do that and not study it. You have to devote your time to this so that you know this stuff. Now, for the most part, you got most of them right, but when it started getting specific with these drugs, you drew a blank. So tonight, when you're studying, go over these drugs, those basic bronchodilators that we talked about. What is the trade name? What is the generic name? What's the concentration of it? What's the receptor effect? Like I said, what is the receptor effects of bronchosol? You need to know it's alpha 0, beta 1, 1, beta 2, 3. Okay, you got to know that. You got to know. It's not going to be easy like what's the same thing as albuterol that's just beta 2. Oh, so it's not that easy. It's going to be a little deeper than that. It's going to ask you questions about cystic fibrosis. It's going to ask you questions about the mucolytic drugs. Okay, mucolytic drugs. All right, so mucomyst should always be given in combination with what? A bronchodilator. Bronchodilator. All right, steroids. Steroids work by doing what? How do steroids work? Decrease inflammation. By decreasing the inflammatory response, right? Decreasing the inflammatory response. All right, now y'all write this down. If you have 10 milligrams of a drug that's a 1 to 200 solution, 10 milligrams of a drug. Is everybody able to get on the Zoom now? Y'all on here? Oh, okay. Well, let me. I should be able to show it on here then. Number 21. Get to 21 and share my screen.
You said 1 to 200, right? So,
Huh?
You said 1 to 200, right?
Yeah, I'm about to put it up for you to see right now because I'll make sure y'all can see it. We're on number 21. I'm gonna share my screen. All right. All right. Should be seeing it now. 21. You have 10 milligrams of a 1 to 200 solution. How much solution do you need? Wait a minute. I don't know how that. I don't like the way that sounds. Wait a minute. If you have 10 milligrams, I guess it should say if you want. Yeah. If you want 10 milligrams of a 1 to 200 solution, how much solution will you need? How many cc's will you need? If I want to get 10 milligrams and I know I have a 1 to 200 solution, how many cc's do I need to achieve 10 milligrams? Hmm? Just work out the math. Yep. My iPhone trying to get in. If you want 10 milligrams of a 1 to 200 solution, how much solution do you need? Write your answer down or circle your answer. I'll come around and see who got it. And I'll let you work it out so for those who not getting it. Don't forget it's concentration over 1 equals mg's over ml's on the other side. 1 to 200, you got to know what percent that is and then convert that to milligrams. Got it? Okay. It should be real easy right here, guys. You got it, Kayla? Good. Good. Set up right. Do the math. All right. Oh, okay. Oh, you ready? Well, that's good. Good. You ready? Okay. All right. So this is how you set it up. You got it now, Miss Rose? This is how you set it up, guys. I ate all this turkey, it ain't good. All right. I want 10 milligrams. I have a 1 to 200 solution. First thing I said is find the concentration. Concentration over 1 equals milligrams over milliliters. I want 10 milligrams, so I'm going to put that here. That's my desired amount, 10 milligrams. How much solution do I need? That's what I don't know. X. 1 to 200 solution is a 0.5%. In milligrams, that is 5 milligrams. 0.5% times 10, 5. Put a 5 right there. Times X is 5X equals 10. Divide both sides by 5, and X equals 2 cc. That's as easy as they get. The easiest one. But you got to know how to set it up, right? You got to remember how to set it up. That's how you get it. So, what was the problem? What are y'all? Where's your hang up? Where was your hang up? Oh, okay. Yeah, 1 to 200 is a 0.5. 1 to 100 is a 1%. Okay. Then you got to convert that to milligrams, right? So let's look at 22. Do number 22. You have a 0.5% solution. The physician orders 20 milligrams of that drug. How many cc's do you need now? Huh? Oh, you don't have it up? You have a 0.5% solution. And the doctor wants 20 milligrams of that to be given. How many mLs do you need? 22. Should be almost, it should be just as easy as that first one. Good. Raise your hand whenever you got it. I'll come look. Good. 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 That's it. 4 cc's. That was just like the person, just like the last problem with, the 5 milligrams over 1. Now this time he wanted 20 instead of 10, so you double it up. Okay. All right. Number 24. Which drug is beta-2 specific and is an isomer of albuterol? Beta-2 specific. That means all it is beta-2. C. Zopanex. Zopanex is an isomer of albuterol, also known as, what's the generic name for Zopanex? Levalbuterol. Levalbuterol. Levalbuterol is an isomer of albuterol, and it is beta-2 specific, means it has no alpha and no beta-1, just beta-2, pure bronchodilation. Okay. 25. Anticholinergic drugs block the effect of what at the muscarinic receptor site and stop constriction of the bronchial smooth muscle. So anticholinergic drugs block what? Not epinephrine. Acetylcholine. Anticholinergic blocks the cholinergic effect, which is acetylcholine. Acetylcholine, that is on the parasympathetic side, right? The parasympathetic nervous system has acetylcholine as its neurotransmitter. When it trickles down on the muscle, it causes bronchial constriction. So we have to get drugs that block the effects of acetylcholine, which are anticholinergic drugs. Anticholinergic. And what are the two anticholinergic drugs? Or what is the one we use as respiratory? What is the anticholinergic drug that we use? Atrovent. Atrovent. And what is Atrovent generic name? Ipratropium bromide. All right. What is the other anticholinergic drug that is used in surgeries? Atropine. Because the parasympathetic side or the acetylcholine can cause the heart rate to do what? Drop. So in surgery, they're sedated, heart rates can drop, so we can use an anticholinergic to get that heart rate back up or keep it from dropping. Okay? Anticholinergic blocks the effect of acetylcholine. Epinephrine is on the other side. Sympathetic nervous system uses epinephrine as a neurotransmitter. And epinephrine can cause vasoconstriction, causes bronchodilation, can cause the heart rate to go up, right? All these things happen on the epinephrine side. That's the fight or flight, right? Epi, liquid adrenaline, right? That's the sympathetic nervous side. The other side is parasympathetic with the feed or breathe, and it uses acetylcholine as its neurotransmitter. Okay. All right, number 26. What is the phase that describes the time required for drug absorption, distribution, metabolization, and excretion? Pharmacokinetic, the movement of the drug. Kinetics be movement. So time to come in, get used, get absorbed, go out the body. That's the movement of the music. Pharmacokinetic. Pharmacokinetic. 27. What is the term for the action of two drugs, which is the total effects are greater than the sum of the independent effects? C, potentiation. Additive effects is kind of like one kind of enhances the other. But this is saying two drugs whose total effects are greater than the sum of the individual parts. Right? Those, I told you those terms are really close, so you have to really study those terminology that we did on day one. Terminology we did on day one. 28. Which of these drugs are considered to be an anticholinergic, aka parasympatholytic? Which one of these drugs is an anticholinergic? E, ipratropium bromide. You just told me Atrovent, and Atrovent is the trade name for ipratropium bromide. So this is how it looks, guys. This is how the pharmacology test looks. Told you from the day one that pharmacology and what was the other one? The pharmacology was a bugaboo. Okay, it's a lot of medicine, a lot of different things to know about the medicine, but honestly, this class has had longer time to prepare because of the holiday than anybody else. Okay, so you guys, I hope you have been studying, doing your flashcards, and really been serious about learning it, because it's not going to just pop in your head. All right. Go back over those. Go back over those lectures. Lecture from day one. When I talk about those terminology, those bronchodilators, all those things. You know, the PowerPoint that's there with the different ways we use this medicine. Reading the aerosol pharmacology chapter in your book. Have y'all been reading that? Taking notes, highlighting in it, right? It's all there. It's all there. But the main thing, guys, don't be discouraged. The main thing is go back to look at those specific bronchodilators. That's what's biting you. You got to go back and look at the specific bronchodilators from the notes, from the lecture, and just go over there, like you said, the the bronchosol isoethylene, right? metoprolol, and what is the racemic epinephrine. All of those lists that we have. Make sure you know the generic names of it, the trade names of it, and the receptor effects, especially. Okay, so then because it may ask you which drug have the, like if I ask you right now, what drug has equal beta 1 and beta 2 effect? That's something that you should bring out. Oh, that's what you call it, right? That's how you have to learn this stuff. Which drug has equal uh, equal beta 1 and equal beta 2? Not isoprel. But let me look at isoprel to make sure, because it might be more than one. Might be more than one. Let me see. Isoprel, let me make sure, because it might be more than one, because there is. Yes. Okay, there you go. So isoproterenol, which is isoprel, good. 4 and 4. So if it said which one of these medicines have equal beta 1 and equal beta 2, you're looking for what two medicines? Isoprel and metoprel. But it might not say metoprel. What if it says allopen? Remember, allopen is another trade name for metoprolol, right? Metoprolol sulfate has two trade names, allopen and metoprel. So the question may throw any of those out there. You guys, so you gotta know. You gotta know about metoprolol sulfate, right? What's the maximum dose of metoprolol sulfate? 0.3 mL. 0.3. Question will probably have a 3 or a 0.3, right? You need to make sure you know that. 0.3 mL. Receptor effects are beta 1 is 2, beta 2 is 2, right? So that's the kind of stuff that's why I stressed it to you. Please study these terms, study these medicines. Know the difference between your your sympathetic nervous system and your parasympathetic nervous system. The questions in the lab book, those critical thinking questions, you work on stuff like that. Use everything at your disposal. Okay, everything at your disposal. The pharmacology drug calculation should be the least of your problem. I knocked that out, understand how to set that up. But that should be the least of your problem. You have that quiz, so go back. I gave you the drug calculations quiz. You did it. Everybody did well with it. But if you don't study, go back and look at them again and make sure you're able to do it. Because the answers, I even gave you the answers with it. All right? Nah, can't use anything. Now, when you take your oral exam, don't forget. Now, when you take your test tomorrow, when I tell you to clear your desk, I'm going to give you a scrap piece of paper. Whatever's in your head, you can put on the paper. That's why I let you do that. So little things that, you can't wait till had never studied until tonight. That's not going to work. But the things that you've been amassing and learning when, studying, when I tell you clear your desk, you clear your desk. I'll give you a blank piece of paper. You can write several things, whatever you want to put on it. Right? You put whatever you want to put on that paper, and then I give you the test. But, it's all about how much you put in it, especially pharmacology. Now, when you take your oral exam, you're not even going to have paper or computer. You're just going to be sitting there looking, and I ask you a pharmacology question, or somebody asks you a pharmacology question. Tell me, name 2 corticosteroids. You got to be able to name them, right? Any 2, right? Any 2 corticosteroids. Which drug is given for ribavirin? Stuff like that. Which one of these drugs has to be given in it with a one-way valve, right? A nebulizer with a one-way valve. What drug is that?
That's the scavenger, right?
Yeah, which one is that? Pentamidine. See? Pentamidine. What kind of patients do we give pentamidine to? Not the cystic. AIDS patients. What drug do I give cystic? We learned that today. Dornase alpha. Dornase alpha, right? Which one of the mucolytics break down the DNA bonds of the mucus? You can't miss it, right? Which one of them comes in a 10% or 20% solution and must be given with a bronchodilator? Yeah, which one is that? Mucomist, Mucomyst. What is the generic name for mucomyst? Acetylcysteine. So when you see it, it'll pop in, it'll help you, but you know it, like the deoxyribone, you might not could have said all of it and remember now, but when you see it there, that's gotta be it, right? But what's the trade name for deoxyribonuclease? Dornavac. So deoxyribonuclease might not even be in your choices. It may say which one of these drugs works by breaking the DNA bonds of the mucus, and Dornavac might be the choice. It may say Dornavac, Dornase alpha, you know what I'm saying? You got to pick the right one. All right? Now, so let's go ahead and knock out this lab. Knock out your lab. Go ahead and get your pages. I'll give you some time to, I'm going to give you some time to get your pages labeled and separated. Like this. 63, 107, 229, and 233. Those are the lab book pages that have to be. No, lab is today. I said everything is today. The test is tomorrow. We haven't done the lab yet. No. I gotta let you. It's not much. I'm just gonna have you come up and show me a few things, and I'm gonna check y'all. Yeah. Lab and review today. All right, and whatever I did record today, it will be available tonight. I'm ending it right now.